Hello and welcome to Proactively Addressing Diversity in Diabetes. My name is Quisha Umemba. I'll be your presenter for this session. This is a very informal session, and although we cannot talk to one another, I'd love for you to use the chat to engage and interact. So please share your thoughts, comments, and feedback via the chat throughout the duration of this session. So again, my name is Quisha Umemba. I am the CEO and founder, or co-founder rather, of Diversity in Diabetes, in which you're going to learn a lot about in just a little bit. But I'd love to know a couple of things about you before I get started. One, I'd love to know what is your reason for being at the DiabetesMine Innovation Summit this year? And then specifically, what are you looking to get out of this particular session as we discuss ways to proactively address diversity in diabetes? So that's your homework assignment for right now. Share one reason why you're here today, and then what are you looking to get out of this session? So I'm going to be speaking with you for about 20 minutes, and while you're doing that, thank you so much for entering those responses. I'm going to go ahead and cover my objectives for this talk. So there's three things that we're going to talk about in our time together. I'm going to discuss the need for diversity in diabetes, and not just our organization, Diversity in Diabetes, but why diversity is needed in the diabetes space. I'm going to review some common challenges that people of color living with diabetes often face, and then we're going to talk about some simple approaches that we can use to advance health equity in diabetes care and management. Thank you again for putting your reasons for being here today and what you're looking for to get out of today's session. I appreciate your involvement. Thank you so much. So let's begin the conversation and talk about the need for diversity in diabetes. I have to start this section off by telling you the story of Ebony and Ivory. Ebony and Ivory is just kind of an internal reference that my co-founder Casey Creel and I refer to ourselves as. I met Casey Creel at a diabetes conference in March of 2020. And a little bit about my background: I am a registered nurse. I'm a certified diabetes care and education specialist. I do have prediabetes, but I've worked with patients that have diabetes for several years. And then Casey was diagnosed with type 1 diabetes at 7 years old. And so we both met tabling this event where we were ambassadors for the College Diabetes Network. Really enjoyed our time there together, getting to know one another, finding out that we had a lot of commonalities despite being really from two different walks of life. And I told Casey, you know what, I'm going to walk around and just, visit each of the vendor booths and, see what I can see and go into the main auditorium to listen to some of the sessions for a little bit, and I'll be back. And so I went. I think I was away maybe 30 or 40 minutes. And one of the things that I noticed as I was gone was like, there's nobody that looks like me here, which was striking because I'd never been somewhere where there was probably that lack of diversity in a educational setting that consisted of information catered to an audience with chronic disease. All of the speakers are white, and all of the vendors, with the exception of myself and one other a young woman that was representing one of the local hospitals. So we really started talking about how of all of the education that needs to take place in the diabetes space, certainly diabetes tailored and geared for people of color was much needed. And so for the next several hours, Casey and I really just had these kind of pipe dreams, and really talked about what a perfect world would look like if it existed, and how there would be access for all, and how we could reach, people from all different backgrounds and ethnicities and languages. And then about 4 or 5 weeks later, get a text out of the blue saying, hey, this is Casey Creel. We met, at the Diabetes Summit, and just wanted to know if you wanted to put on that virtual event for people of color living with diabetes. And really, the rest is history. Immediately after, probably in about 90 days, we actually hosted our first People of Color Living with Diabetes Summit. Realized even before the summit started, that it was work that was just wanted by so many and certainly needed, and decided to go ahead and start our organization, which is called Diversity in Diabetes. Before I go any further into diversity in diabetes, I must provide this disclaimer, and this is a quote, actually a snippet of a quote that I'm going to read to you, that Casey, went back too far, that Casey actually responded to an individual on our social media page about, because a lot of times individuals think that Diversity in Diabetes is an organization that caters to everyone but white people, so we catch a lot of flack about that sometimes. But I think it's important that when we talk about the word diversity, that you understand the word diversity in diabetes simply means that we bring a diverse voice and perspective to the diabetes space. We understand that there are certain populations that have not been routinely heard from, and we think the diabetes community would benefit from listening to everyone. Her quote goes on to say, ultimately, we want to bring diabetes support and education to everyone living with diabetes. And one way we do that is by highlighting the voices that haven't been heard from before. But this in no way means that we exclude anyone. So when we say diversity, we mean diversity in every single sense of the word. All are welcome. So we founded our organization as soon as the first annual People of Color Living with Diabetes Summit ended. That was August 2020. In fact, we just obtained our 501c3 status this past August. And our mission is to create awareness and provide solutions to end health disparities and the lack of representation in the diabetes space. And one of the ways that we think that we're unique over other organizations is that we really advocate on behalf of all individuals with diabetes, regardless of the type of diabetes that one may have. So we have some priority areas that our work centers on, and it really wasn't difficult to pinpoint these areas. We know that people of color and other marginalized groups don't access diabetes education and support at the rates of non-Hispanic whites. We know that they're often not aware of different diabetes treatment options available to them. We know that they don't utilize diabetes technology at the rates of non-Hispanic whites. And we know that there's a serious lack of representation of healthcare providers and diabetes educators of color. And so we felt that it was imperative that our work center around these areas. We also are considering a fifth focus area because one thing that is really important is representation in clinical trials and research studies. We've got a lot of partners that are wanting to do work in this area and wanting to see improvements and certainly increases in numbers in these areas as well. So we're actually internally discussing the feasibility of adding this as a fifth pillar. So who do we serve? Again, we serve everyone, right? Our focus is on BIPOC individuals and communities, but we don't exclude anyone and we don't discriminate. Our priority populations include Blacks, Indigenous, and people of color, especially those that live with diabetes, community organizations, nonprofits, healthcare systems, healthcare professionals, and of course, diabetes educators. You can never have too many CDCESs. At DID, Diversity in Diabetes, we really pride ourselves on being able to walk the walk and not just talk the talk. We do realize this day and age that DEI, diversity, equity, inclusion, is a hot topic. But, we're really selective about the organizations that we partner with, and we really do our best to ensure that we work with partners and clients that realize they have more work to do and that they're intentional about improving diversity efforts, not just checking off the diversity box. In the short time that we have been in existence, we've been fortunate enough to have the opportunity to serve as priority population and subject matter expert consultants for the Association of Diabetes Care and Education Specialists, hosting workforce development trainings for the diabetes prevention programs, focusing on cultural competency and health literacy. We do provide a variety of consulting services that include providing guidance on culturally competent diabetes program implementation, on evaluating diabetes programs, diversity and inclusion practices, on providing technical assistance on marketing campaigns, educational materials, and other tools intended for the BIPOC community. And of course, we create awareness by speaking and presenting at various virtual events like this one. We were fortunate enough and really excited enough and grateful that we were able to secure a grant that allowed us to launch our virtual diabetes education program this year. The VDEP, as we call it, is a 12-week education and support program. It consists of 2 phases. So phase 1 is a weekly 6-week program where participants meet for an hour and a half and get education with a diabetes educator. And phase 2 is 6 weeks of support where you communicate with a community health worker who's also been trained in diabetes education and through a phone application. So a smartphone app in which they can take pictures, they can send messages or questions to the community health worker, and they have that additional support for another 6 weeks. So we're really excited about that. We also will be starting our support group starting in 2022. So we're excited to be able to offer a variety of support groups, especially for our type 1 community. Our type 1s are really, really hungry for education and support, and we're extremely excited to be able to provide this for them because there's really not a lot out there for individuals that have type 1 diabetes. What we're probably known for more than anything is the People of Color Living with Diabetes Virtual Summit. So that's the picture that you see there. We just actually hosted the summit for the 2nd year in a row. Our goal with the POCLWD summits are to promote awareness, create a sense of community, and provide an opportunity for stories to be heard. We want to provide that safe space for people to be able to do so because, like I said before, a lot of people in the diabetes community have not felt free to vocalize their experiences, which are often invalidated by others. And so just having our summit, I'm proud to announce that our summit was attended by 686 individuals representing 32 countries. And to me, still being an organization that's in our infancy, 2 women that, really didn't know each other at all, coming together with a shared kind of common interest and common purpose. I think that's a great feat that we've been able to achieve in just a short time. So now let's talk about some diabetes-related challenges that people of color experience. I've already alluded to some of the racial and ethnic health disparities that led us to the development of our 4 priority areas. We all know that race, ethnicity, and social determinants of health significantly influence outcome for diabetes patients, but to set the tone of the conversation so that I can provide you with these really simple approaches that you can use, I'd like to share some stats with you to show how people of color are incredibly affected by these factors that usually lead to higher diabetes prevalence and poor health outcomes. So in the United States right now, about 8 million adults, more than 1 in 3, have prediabetes. More than 84% of those individuals don't even know that they have it. And when I say prediabetes, I'm talking about when you have higher than normal blood sugar levels, but they're not quite high enough for you to be diagnosed as having type 2 diabetes. Prediabetes, however, does not come without its risk because it does carry a risk for type 2 diabetes, heart disease, and stroke. When it comes to diabetes, 34.2 million people of all ages have diagnosed diabetes. That's about 1 out of every 10 individuals. And 1 in 5 people don't even know they have it. And you guessed it, when it comes to the prevalence of diabetes, people of color have the highest among ethnic groups. Among American Indians and Alaska Natives, 14.7%. Among people of Hispanic origin, 12.5%. Among people of non-Hispanic, Black, and African American backgrounds, 11.7%. Non-Hispanic Asians, 9.2%. and non-Hispanic whites 7.5%. Some other stats and challenges for people of color living with diabetes. People of color living with diabetes experience a 60% higher chance of being diagnosed with diabetes than whites. They are twice as likely as non-Hispanic whites to pass away from diabetes and to be admitted to the hospital with uncontrolled diabetes at a higher rates than whites. I've already said it before, they're largely underrepresented in research trials. Medication adherence is a big factor in people of color communities. People of color are more likely to be diagnosed with diabetic complications, including end-stage renal disease, limb amputations, and uncontrolled high blood pressure when compared to white Americans. They have lower rates of diabetes management education and diabetes health literacy. And this is exacerbated by research showing that many education programs are not very successful in reaching people from minority ethnic groups. African Americans, Hispanics, and Asian Americans were all found to have significantly higher hemoglobin A1C levels compared to non-Hispanic whites, indicating poor glycemic control. And studies have found that African American women with gestational diabetes, like I had with my second son, have a 60% higher rate than Hispanic women and non-Hispanic women of developing diabetes later in life. So as you can see, there are quite a few challenges and even some obstacles in the way for people of color living with diabetes. So now let's transition to approaches to advance health equity in diabetes care and management. We realize that this work is not easy, and so knowing that Rome wasn't built in a day, I know that these things are not going to happen overnight, but there really are small steps that we all can take to ensure equitable health care for all of our clients, all of our patients, and all people of color, or all people in general living with diabetes. So what I intend to share with you in this presentation is what we consider low-hanging fruit, okay? So first things first, this really is geared toward the healthcare providers. Refer all people with diabetes to diabetes self-management education, right? I like to say refer everyone, period. Doctors, you guys write a lot of prescriptions. And if diabetes education was a pill, I am sure you would prescribe it. But it's not prescribed. You're not referring your patients. In fact, according to health.gov in 2017, only 60% of people with diabetes have formal diabetes education. And since we now know there are more vulnerable populations that are already projected to have or already have the highest prevalence of diabetes, we have to be intentional about making sure that we increasingly target those most in need and most at risk. Therefore, education and prevention programs are a must. Results of formal diabetes education programs see an increase in the use of primary care and preventative services. Patients are more apt to take their medications as prescribed, and you see better glucose control for individuals that understand how what they eat affects their blood sugar, how their weight affects their blood sugar, how their physical activity affects their blood sugar, and how to prevent complications. I mean, I'm just giving you a snapshot. There's so much more that they learn when they actually participate in diabetes self-management education and support, but it starts by first referring our patients, right? I remember when I was the program manager of a diabetes education program in Houston, I had a provider liaison that would go out to develop these bi-directional referral relationships with our community providers. And she came back one day and said, I was talking to this doctor and he said he knew about our program, but he wasn't referring his patients. And she said she asked him why. And he said, oh, well, these patients, they're low income and, many of them are single mothers with multiple children and they're probably not going to come anyway. So I don't even mention it to them. That's not his decision to make, right? And so my provider liaison had to say, just give them the referral or add their name to a referral list and fax it to us and we can reach out to them, right? And so a lot of times providers, not just doctors, I don't want to just beat up on the physicians, but provider healthcare professionals in general will speculate what we think a patient will or won't do, and it will stop us from taking the appropriate action. So refer everyone, period, is a simple strategy to ensure that more people receive DSME services, or at least they're aware of them. Maybe they're not motivated to change right now. Maybe they're not motivated to act right now, but they know that that resource exists. So maybe 3 months, 6 months, a year from now, they will be able or in a better position where they can actually participate in DSME. The second strategy is really tailored toward organizations and healthcare systems. You know, one thing that we talk about in public health is meeting people where they are. Well, guess what? You can meet people where they are virtually. In fact, this is what we do at our organization, Diversity in Diabetes. People are continuing to get more comfortable in the virtual space. They're adapting quite well to virtual classes. So you can offer, you know, a variety of programs and services virtually. Yes, you're going to have to consider technology issues. Yes, there's going to be learning curves. Yes, you may have to have technical support or somebody that's on the call that's going to be able to help people that are having issues at first, but you can overcome these issues, these barriers with proper planning and execution. So we are already implementing the virtual diabetes education class. We've got plans to start our virtual diabetes support groups in 2022. And then we just featured the virtual nutrition classes, the virtual fitness classes in our People of Color Living with Diabetes Summit. And most organizations now are already implementing virtual telehealth visits. So please meet people where they are virtually. A third approach is for everybody. You have to consider culturally tailored interventions. People of color often feel powerless when it comes to managing their diabetes. They often feel like so many things are being taken away from them. I can personally speak on behalf of many of my patients. They feel like, you know, life is over. I'm not going to eat the things that I liked anymore. I'm not going to be able to go to the same restaurants. So it's really important to consider the impact that culture plays in managing a person's diabetes. In fact, a good educator or a good clinician is actually going to work with the client to help them celebrate their culture in spite of diabetes, okay? So be mindful of the cultural stigma that they may be facing. Learn the cultural nuances of the individuals and the communities that you work with to help overcome obstacles. I like to use this image because a lot of people don't necessarily know that Black women, we don't have a problem with exercise. We have a problem with messing up our hair, right? So I'm not going to exercise and sweat out my new do if I just spent 2 or 3 hours getting it done and $200 or $300 getting it done, right? So this is a real thing in the Black and African American community, but you may not know that. I know that, so I can work with my client and talk about, you know, doing chair exercise or low impact exercises, or, you know, squeezing in fitness routines in between those hair appointments, different things like that. But you've got to learn those kind of cultural nuances in order to be able to work with your patient appropriately. Marketing and outreach should include diverse and ethnic representation. Education programs and curriculums should also be culturally appropriate as well. I've heard patients complain of going to see a nutritionist or going to see an RD, and that person, that individual, will tell them that they've got to stop eating rice, or that they've got to stop eating cornbread, or they've got to stop eating something that's a staple in their community. And that's just not, you know, it's not realistic. And so we have to make sure that we're incorporating culturally tailored interventions. The next strategy, again, is for organizations and healthcare systems. And this is using community health workers. So if you don't know, a community health worker is a frontline public health worker who is a trusted member of a community, or they have an unusually close understanding of that population that's being served. And so a community health worker serves as kind of the intermediary, the link between health and social service programs and the community, and they help facilitate access to services. They help improve the quality of care. They help improve cultural competence of service delivery. I always say CHWs have a superpower of trust, because it's that trust and that rapport that actually helps them to see the interventions that have been proven as a result of utilizing CHWs in the workforce. So the Community Preventative Services Task Force, they recommend interventions that engage CHWs in team-based care models. Chronic conditions like hypertension, cardiovascular disease, diabetes, all of those are great programs to embed community health workers in. On a personal note, I oversaw a community diabetes education program, like I said, at the Houston Health Department for 5 years. And I oversaw multiple diabetes education cohorts that were taught by numerous staff. Some of the classes by an RN, some by an RD, some by a fitness trainer, and the others by CHWs. And one thing that I saw consistently over the course of the 5 years that I was there is that the program participants in every single class that was taught by my community health workers saw better outcomes across all categories. Every single category: waist circumference, BMI, A1C, customer satisfaction, blood pressure, every single category. So I could quote you a handful of research studies that speak to the effectiveness of CHWs, but my little personal observational study was all the evidence that I needed to understand the value of community health workers in both the clinical and community setting, and that's why I train in my personal business, Umemba Health. I train and certify community health workers, and I teach them how to integrate in the clinical setting. So this is one of the top strategies that you can employ. Maybe it's not a low-hanging fruit, but it's something you certainly need to look into, especially if you're not familiar with that term, community health worker, because it could be the missing link to your organization. And then the last strategy I'm going to leave you with, this is more for on the individual level. We like to say this at DID: don't just be an ally, be an accomplice. It's great to be an ally, uniting yourself with another person to promote a common interest, right? That's what an ally is. But it's even better if you can be an accomplice, especially if you are a healthcare professional, a diabetes educator, a person that's in a position of power or influence. Recognize the power that you have, recognize the platform that you have and your position to help amplify the voices of those that are unheard, especially if you're a member of the majority, i.e. white population, right? Be an advocate, speak up on another's behalf. And in order to do that, be an advocate, be an ally, be an accomplice, it really does require self-awareness. And this is taking a long, hard look in the mirror and being honest about your biases. Oftentimes, people think that if we're biased, we're bad people. No, having bias doesn't make us bad people. Having bias makes us human. It's acting on those biases, right, in an untoward way that makes what we do bad. But be honest about other people's experiences, especially people of color and their lived experiences, and ask why people's experiences are different. And when they share those stories with you, validate those experiences, show empathy, and be non-judgmental. I like to share a story because a lot of times when I talk about don't just be an ally, be an accomplice, people don't really understand what I mean when I say this. So I like to share this story that I kind of titled Pam's Sacrifice. It's about one of my best friends. Her name is Pam. She identifies as white. She's half Colombian, half white. And it was after last year, so 2020, after George Floyd had died, probably about 3 days later, and I was still a mess, as I'm sure most Blacks and African Americans were at the time. And she called me one day, like she does every day, and she's like, Quisha, I don't know what to say. And I was like, it's nothing that you can say. And she said, you're right. There's nothing that I can say, but there's something that I can do. And I said, Pam, what do you mean? And she said, Quisha, if I'm ever in that situation where I witness something like that, she said, I'm going to put myself in front of the gun. She said, because I know the police is not going to shoot me. And when she said it, I literally got goosebumps all over my body. Of course, I started sobbing again because I cried for several days at that point. And I thought, that's how you use your whiteness as a weapon. And so your idea of being an advocate, ally, accomplice doesn't have to be that extreme. If you knew Pam like I know Pam, you know she was telling the truth. And so that's why I call that story Pam's Sacrifice. But that's an example of how you be an accomplice. That's an example of how you go to the extreme when you are advocating on another person's behalf. So I'm going to leave you with this quote before I end my segment today. It says, "Of all the forms of inequality, injustice in health is the most shocking and inhumane." Dr. Martin Luther King Jr. Race and ethnicity are barriers to equitable diabetes care. We know this. I've reviewed this in this session. And hopefully the approaches that I've shared with you today can help move us in the right direction. Thank you so much for your time today. Look forward to your questions.